Okay, our first session is about communicating the pregnancy weight guidelines, and this is our chance to tell you about the products of the committee. And there will be two speakers, me and then Dr. Sc.D. I'd like to begin by just showing you the poster. This is color's a little bit washed out, but we have a lot of light on us. The posters are in the back over there for you to see. I want to, by this introduction, tell you about the context of our work and how we thought about disseminating the report. And then Dr. Sc.D. is going to introduce the products for you. Now, let me see here. I am assuming that is there we go. That's the next slide. This is what I classify as manna from heaven. Earlier this week, Dr. Andrea Sharma from the Centers for Disease Control shared with us this analysis, which is the very latest data for full-term singleton births in 2010 from the PRAMS data system. Now, I want to let you know that PRAMS only covers 28 states and the city of New York. So these are not nationally representative, they are not even national data, and they are the best data we have. So I want to focus here on the four bars on the left, underweight to obese women. And what's graphed here is women who gained in the green above the guidelines, in the red within the guidelines, and at the bottom below the guidelines. And if you look, you'll see across these four bars, only a minority of women gained within the guidelines, a low of 22.8 among obese women and a high of 40.7 among normal weight women. In fact, more women gained above the guidelines than in any other category, as much as 64% among our overweight women. This is, in fact, what we expected would happen when we revised the guidelines, because it did change who was in what category. And of course, we did go to the NCHS definitions for obesity and for BMI in general. So we expected this, and this is what we saw. On the right are the three bars on the right are data the committee never had available. These are data on women in obese class 1, 2, and 3. And our obesity recommendations primarily derived from women in obese class 1 because we didn't have the separated data. And when you look at these data, you see as few as 18% of women and as many as 22.9% of our women who are obese actually gained within the guideline. And the preponderance of the problem was, of course, gaining above. We actually see some women in obese class 3 gaining below the guidelines. 32.4% of them gained less than 5 kilos, so that's what, 11 pounds. We did not have sufficient information when we developed the guidelines to be able to say whether that was a net risk or a net benefit, so we are beginning to collect the data that we need to do this. So the point here is that these very latest data make clear what we saw when we wrote the report, that the preponderance of women are gaining outside of the guidelines, and most of those are gaining above them. This is not the situation we would like to see. Now, one of the reasons that we have to disseminate the guidelines is just the facts that are portrayed in this slide, that women need help gaining within the guidelines. In fact, the vast majority do, and that it's pretty clear that we need to think really quite holistically about this if we want to achieve this goal. So my next slide introduces what is really a complex situation. Now, I wish I had had access to such clever graphic artists when I've made slides for my teaching, but I don't, and this graphic artist has turned my box and arrow diagram into something really, really fun to look at. But this is the framework that the committee developed together, and it guided our deliberations. Over here on the right is the target, which is having women actually behave the way we are asking them to, which is to gain within the guidelines. But of course, I've just told you they're not. So let's see what else is going on and what our opportunities are for making a change. So let's start down here at the lower left, which is the consensus study on weight gain during pregnancy, and see where it can work and what else we can do. So this report has been used in many ways. It has been used to inform professional society opinions through the report, this workshop, the workshop that actually preceded the committee, and of course the medical literature. One of the things the committee did was to write a response to an editorial that appeared in the journal called Obstetrics and Gynecology, which basically told us we were all wet and we weren't too happy about hearing that, so we wrote back. And as Dr. Connie was saying, continuing medical education is an opportunity to educate physicians, and that paper, not the report itself, but our riposte to the obstetricians and gynecologists who wrote the original commentary, became one of the continuing medical education exercises for obstetricians and gynecologists. Maybe we ought to look for one of those from this committee and see if we can find another way to do that. Now, when we have a society opinion, what that does for us is that allows us to create a standard of care if it's picked up by the society. When a committee like the Weight Gain Committee writes a report, we are suggesting public health guidelines, and they are adopted for that purpose, but they don't penetrate medical care unless they become a standard of care. So we want the health team to learn about the care from their professional societies, with staff training to develop tools that are based on the actual standard of care, and to have the health team taught and then have the health team teach women. This standard of care interacts with two other parts of the medical care system that we thought carefully about. One is the electronic health record. I'm told that's the new way of referring to the electronic medical record, and the medical payment system. Now, what the committee learned as part of its work was that the train had left the station for Obamacare and rulemaking about the health record and about the medical payment system. So this was not something we could influence. But there are people in this room who do have influence on that particular lever, and if that's you, please think about how to make this happen. We also found that the electronic health record is influenced basically by the 4 or 5 providers in the country that actually create these, and that many of them already have appropriate units on the obstetric visits, but also hospitals are not choosing to use them. So we have the opportunity there to think about actually using what's already available in your medical care system. That's you in the room and you who are watching us on the internet. We think that that's a real opportunity, something the committee couldn't do much about, but we do want to highlight that possibility. Okay, so now women are learning about the guidelines. They could be learning from their healthcare providers, but they could be learning a lot of other ways through the media. For example, the media that picked up our report. Unfortunately, not all the media outlets who picked up our report, and we did survey them, actually reported accurately what our guidelines are. And in fact, in some places, obese women completely disappeared. Apparently, they chose not to show the separate guidelines for obese women, which is a real disservice, I think. There are internet resources that women can contact. There are mobile applications that can be used. There's information in the doctor's office. And some of what we're providing that Anna Maria is going to talk about soon is in this category, both of addressing women and addressing what they might find in the doctor's office. Okay, so now women learned about the guideline. Next, they have to make the choice to actually try to gain within the guidelines. I want to emphasize to you that this is a choice. It's a behavior on their part to decide that they want this to be their goal. And you've heard about, from the obstetric point of view, motivating the women for them to recognize what an appropriate weight is for them, what therefore an appropriate what they weigh now, and what an appropriate target might be if they want to get to what their weight is that they want. And we recognize in this process family and friends, the eating environment in our country, our social cultural context, and of course advertising up there, are all related to women actually making the choice to try and gain within the guidelines and achieving that goal for themselves. So as you'll see, we have materials that are trying to address many parts of this process. We also recognize that there are many leverage points. Some of the ones that maybe can do the heaviest lifting are on the left side of the diagram. That's not what this committee was necessarily able to address itself because of its unique setting within the National Academies environment. But there are also many other opportunities for physicians, for various other kinds of healthcare providers to play in this game. I love Dr. Connery's prescription pad with the guidelines on it and the exercise prescription. Those are definitely things to think about. So now, without further ado, I'd like to introduce Dr. Seeger-Rees from the committee, who's going to tell us in more detail about the products that you see in the back of the room.